about the skepticism?
Well, if you have a debate, I think that I already won, because indeed nobody can say that the yes or the no were really winning, because indeed there are some doubts on both sides. So indeed going for the perhaps is probably the most easy. And one of the things is that Andrea began to present us that, yeah, we have a decrease in troponin with beta blockers, that's fine, but is it really an issue? Well, some people may argue that indeed, if you look at the impact of the beta blockers, it may be beneficial for several good physiologic reasons. But protecting the heart is really necessary. Well, we may find that looking at data from patients dying in septic shock, we may have lesions that are associated with adrenergic toxicity. And this is a very interesting data from Austria. The problem is that this patient was, of course, post-mortem only, so we have no other controls. It may be due to sepsis as well as adrenergic agents, because indeed they were not septic control, dying without vasopressors, and maybe more importantly, decreasing the adrenergic load by giving a non-adrenergic vasopressor agent like vasopressin was not associated with a decrease in these lesions. And perhaps even more, prior beta blockade does not affect these lesions. So even if you have these lesions, giving beta blockers may not protect your heart. So do we have, looking at experimental data, something supporting the use of beta blockers or not? And probably yes, we have, but again, with major caution. Because indeed, this trial already mentioned by Antoine Vieira-Baron was quite interesting, because they look at different agents, different routes, and more importantly, different models. And this is very important in experimental conditions, to really look at what is exactly the model. And what's observed is that there was a decrease in heart rate with beta blockers, hopefully. And surprisingly, at least at that time, that the stroke volume was, if not preserved, I mean, it was preserved or even increased with these beta blockers compared to the control. So this is something interesting, because if you look more in depth of the data, what could be the mechanism? Well, interestingly, there was a decrease in the contractility, as you may expect, of course, from a beta blocker. But also, diastolic function was also impaired in these animals. So you have a better stroke volume with an impaired contractility, impaired diastolic function. So the only plausible cause is that it is just the diastolic time that is playing a role here. And so just allowing time for the ventricle to fill is really probably the most important effect of beta blockers. And so at some point, and we do not have the data admittedly now to say it is better or not, the question will be, should we use beta blockers to slow down the rate, or should we use alternative techniques? Ivabradine, as already mentioned, but maybe others, like Frederick Schogen used, cooling of the patient, controlling temperature, that can be already something that can indeed just lower the heart rate and allows the filling time to be increased in these conditions. The cardiac performance seems to be improved, and this is again something probably very interesting, because indeed this animal trial and some others from Bruno Levy later on just confirms that the cardiac performance is improved. So this is something that indeed is the message of Andrea, that you spare less energy to produce the same output of the heart, which is probably something of value for our patients. So we have really good data that beta blockers spare the heart, but do our patients die from acute myocardial infarction? Probably not, and we probably also have to pay into attention the fact that we should prevent hypoperfusion to occur. And these data, among others, really shows that early aggressive interventions to try to improve oxygen delivery are associated with not only better perfusion to the cells, but also lower intensity of inflammatory processes. Here using beta stimulation. And also less mitochondrial dysfunction. And again, if you look back at the reverse data, when you have more use of dobutamine, not more use of beta blockers, you have there indeed a lower expression of inflammation in these conditions and also lower expression of caspase, so less apoptosis in these conditions. So there is a clear link between hypoxia and inflammation, and you have two different and interesting review articles in the New England that should read to really understand the link between these two factors and understand why you need to be active at the bedside and not just sleeping when your patient is coming with a shock in your unit. The other aspect, which is really intriguing, is that at least in experimental models, beta blockers may also exert anti-inflammatory effects. Admittedly also, it's not always on the same pathways that some trials show an effect. So here, the Bruno Levy was mostly looking at the TNF and NF-kappa-B effect, while in this other group here from Belomo in Australia, they found that no, TNF was not really affected, but yes, IL-10 was affected, and so the anti-inflammatory cytokine was more present in these animals. So there is something about inflammation, but the pathway is not so clear, but obviously something is working there. We need to be quite cautious about these trials because indeed, again, we see that usually beta blockers are well tolerated, but often it is in animals with really well-controlled blood pressure and also well-controlled cardiac output. And more importantly, no organ dysfunction, no tissue hypoperfusion because lactate levels are normal in most of these cases. Also, sometimes the presentation of the data is a little bit difficult because indeed here, obviously it seems to be just, okay, it's constant, it's stable. Yes, but stable at a very low level, so maybe it's not something you wish to have for your patients. So also, the counterpart, giving dobutamine, a beta-1 stimulation, is associated with an improvement in the microvascular perfusion in the gut, in the liver, and indeed, again, in another one, improvement here with dobutamine and impairment with esmolol in these conditions. And it's not only the flow, it's also the hypoxia as reported by the redox states, which is indeed improved by beta stimulation in these conditions. And it's not only hypoxia, it's just the death rate of these cells, which is indeed prevented by dobutamine compared to nothing. And esmolol was not very effective there. And this is also true in other trials where indeed the beta-1 receptor blockade promotes cell death in ischemia injury. Ischemia reperfusion, not good to have beta blockers there. And here again, another trial showing again that beta blockade is associated with the higher the dose, the higher the cell death rate in these conditions. So this is really trouble because indeed in some conditions you may have beneficial effects and some others detrimental ones. So what about septic shock? This trial was shown by Antoine already. And so again, we need to pay attention to the timing, but more importantly also to the model because it was effective in endotoxic shock, but not in cecal ligation perforation and not in fecal peritonitis. So depending on the model, it may be effective or not. But also, if you block the beta-2, not the beta-1 receptor, so blocking the beta-2, you have an increased mortality in these animals compared to nothing. And if you give dobutamine, a beta-1 stimulator, you have an increase in the duration of survival of these animals. But in another trial, you give a beta-1 blocker, and you have an improvement in the mortality in this model. Do you understand something? You brake, you accelerate, whatever you do, you increase the survival of these animals. So we have to be very cautious looking at this, and obviously we really have variable impact on the mortality in these animals, even sometimes playing with exactly the same receptor. So what about patient in septic shock? Well, previous beta blockers seems to be indeed associated with a better outcome, but we have to be quite cautious here, because if we look closely, 75% of these patients had no organ dysfunction. It is not even sepsis with the new definitions. It is just a simple infection. Flu. Okay, with flu, I have no issue to give beta blockers in my patient. But what about real septic shock? Well, we need to look at what is called septic shock. And here you have this trial here, one of the preliminary trials, showing that indeed esmolol given to these patients was a decreasing heart rate. But look at the heart rate to begin with, 142. Do you often see patients at 142 in your unit? Not really. And they were happy with 112, which was something that would worry Andorra morally, because this was almost its inclusion criteria there. And indeed, cardiac index was somewhat preserved, so volume indeed slightly increased, even though not significant, but only 10 patients admittedly. No impact on the filling pressures, and slight increase, but not significant again, in norepinephrine. But one of the questions, of course, is these patients were in septic shock. They say so because indeed they were treated with norepinephrine. However, mean arterial pressure was 85 to begin with, and a quite low dose norepinephrine. So perhaps just by decreasing norepinephrine dosage would have led to the same results. So we need to be quite cautious looking at these data. Another set of data here from Schmittiger, and what's observed is that indeed 40 patients, they give metoprolol, but also vasopressin, milrinone. Again, you brake and you accelerate on the other side. And then what's observed is that, okay, no change in blood pressure here, and even though a significant decrease in heart rate in these conditions. But again, are these patients really in shock when you look at this very high blood pressure to begin with? Probably, again, this kind of data doesn't help us too much to know if we should give beta blockers or not. Nevertheless, if you look at the safety aspect, well, of course, symptomatic bradycardia was not observed, but an increase, a significant increase in norepinephrine dosage was observed in 1/5 of these patients, a decrease in cardiac index in 1/6 of these patients. And so this is, despite the fact that they increase milrinone in another 6 of these patients. So obviously, it can be tolerated, but you still have to make some actions there. And of course, the most impressive trial is the Andrea trial, looking at the slowing of heart rate with esmolol in these patients with septic shock, and indeed, preservation of blood pressure, preservation of cardiac index, and a slight increase in stroke volume in these patients. And this very interesting trial here showing indeed the heart rate reduction with esmolol. Even though, again, you need to look closely at this data, because it's important to realize that, again, there was here in that data, the decrease in contractility was really something very important. And so it's important to realize that stroke volume was preserved despite the fact that the contractile function was impaired in these patients. So indeed, the clue may be the decrease in the afterload, even though we admit the concerns raised by Antoine there. And the additional question would be, is it, if it is the afterload because you just slow the heart rate, is it better to do it with beta blocker that impairs the contractility, or to use other agents, other therapies that do not affect the contractility, but also effectively decrease the heart rate? And I think that the jury is really out at this stage for this aspect. Some other trials looked at the impact of beta blockers. Here you can see a much more severe population. Lactate is no more normal. You can see that in these conditions, lactate is 8 or even 9 in these patients. Whoa. so high, and you can see here the PCO2 gradient, which is 10 in these patients. So huge signs that the tissue perfusion is really impaired. And nevertheless, I mean, the esmolol is quite well tolerated here with blood pressure, which is stable, and the stroke volume was even increased. But interesting data, it shortens the ICU length of stay. But something really astonishing for me in these data is the mortality. 5%, 8% in patients with a lactate of 10. Quite surprising, isn't it? Yes, I agree. So yes, I mean, you have this data in literature, 150 patients. In meta-analysis, this will be appearing as a pronounced effect of beta blockers. But look at the data. Maybe something quite strange in the population, and you have to be careful when looking at these later on. Are we always happy with the hemodynamic effects of the beta blockers? Maybe yes and maybe not. I mean, an interesting data, again from China, looking at all these hemodynamic effects, and what they observed is that most of the cases there was some improvement in most of the aspects, and again, here no change in troponin levels here in these patients. But interestingly, again, they looked really at quite severe patients with a 0.5 of norepinephrine on the average. But one of the factors is that they looked at patients who increased stroke volume and patients who decreased stroke volume. And this is quite interesting because the impact on the contractility seems to be, or the filling seems to be something important, because indeed the contractile function to begin with assisted here by the movement of the mitral annulus. And so the higher the movement of the anterior movement of the mitral annulus, the higher the contractility and the filling of the heart. Indeed, when it was higher in these conditions, when they give beta blockers, there was an improvement in stroke volume. However, when it was lower than this value, then unfortunately there was a decrease in stroke volume in these patients. So perhaps patient selection to receive this kind of administration of a beta blocker is perhaps very important. It's not just heart rate, it's not just indeed the other aspects that we should take there. And then a final word of caution again about these patients, and I will not go too much here, but the fact that indeed these patients are selected by heart rate, but at the end as minimal signs of tissue hypoperfusion. So yes, these patients were stabilized when they received beta blockers. Do not do it when your patient is still on the hypoxic range with a high lactate and a high PCO2 gradient. Also mortality, which was quite unexpectedly high in these patients, especially when you compare to other patients meeting exactly the same entry criteria. Vasopressors at 24 hours and heart rate about 95. And you can see that mortality there is also 50%, so maybe not exactly different as the treated patients from the Abbiamo trial. So it is very unlikely, in my mind, that esmolol alone can be responsible for the decrease in mortality in the trial, in the JAMA trial. And so, indeed, I think that the impact on outcome is still quite unpredicted in our patients, and we should not jump now to this therapy, because indeed, as these controlled patients appear to be more severe than expected, and the external validity of the trial is really quite difficult to make, and it may be just that by chance these patients were more severe, and that explains a lot of the other factors and effects that we saw with esmolol in that trial. So we need to be looking for more data. And in conclusion, I say that yes, in patients without organ dysfunction, yes, we can try beta blockers when our patients are tachycardic, because indeed, no hypoxia, no organ dysfunction, it's probably a good idea to give it in these patients. In patients with organ dysfunction but without signs of tissue hypoperfusion, again with normal, close to normal lactate levels and so on, yes, perhaps, but again, look at the response to therapy. It is a short-acting beta-1 antagonist, so you can stop it if your patient is worsening. And important in sepsis with signs of tissue hypoperfusion, probably not not at this stage, but I'm eager looking at data because indeed we need to know more about this, and perhaps some patients may still benefit from it, but we need to identify who are these patients and who are the patients who should not receive beta blockers. With this, I thank you for your attention.